Now, moving on to our first section, that is the operation on joints. We will be briefly discussing arthrotomy, orthodesis, and orthoplasty. So, what is orthotomy? What is otomy basically? As you know, otomy means to make a hole in any structure. So, it is orthotomy means to actually open up the joint and to see where the pathology is. Opening up of the joint to remove certain kind of infection, synovial pus, or any debris, doing the debridement of the joint is called as orthotomy. So it is indicated to inspect interior or perform synovial biopsy, drain hematoma or abscess, remove loose bodies or damaged structures. As I told you, if you want to remove something from the joint, you have to open up the joint. Opening of the joint is termed as orthotomy. As you can appreciate, this is the knee joint which is being opened by a medial parapatellar incision, and all the structures are visible. If you want to take a biopsy for any tumor, can be done as well. Hematoma can be drained as well, or most commonly it is indicated for abscess drainage, especially when it is a septic knee arthritis. Or it could be for excised inflamed synovium if it is synovitis, but usually it's rarely for that purpose. So orthotomy is actually intra-articular tissues are there, and as you are into the joint is a sacred place. One has to handle that with care. Post-operative bleeding is usually expected, especially if the large debridement is done, because debridement is usually done for the abscess, and post-abscess debridement there is always an inflamed tissue over there which has the hypervascularity, so there is always a chance that there is increased bleeding post-operatively. For that, usually classical example is after synovectomy, that is usually the synovium is inflamed, hypervascular, and there is also associated problems. So when you take out the extra synovium out, the post-operatively those feeding vessels which were supplying to the synovium continue to bleed, leading to hematoma formation. So for that purpose, we can insert drain, but usually it's said that instead of inserting a drain, it's better to do a meticulous hemostasis during the surgery. Post-operative hemarthrosis could be optional, because post-operatively once the blood collects in, this could eventually solidify to form a hematoma, and eventually hemarthrosis results in, which can be predisposed to infection. So if it was previously there was no infection, there is always chance once you open up the joint post-operatively, this can lead to septic arthritis. So once the procedure has been done, usually the joint, for example, if the knee joint orthotomy was done, we usually put it in a splint that is in a flexion 20 to 30 degrees, so that joint can rest, but that is not for too long. In 5 to 7 days, the splint is removed and gentle range of motion exercise is started, so that we have to prevent the joint contractures as well as to allow the rest and enough rest so that the tissue swelling and post-debridement swelling can be decreased. Now coming to orthodesis. Orthodesis is briefly termed as joint fusion. It is actually a reliable operation for a painful or unstable joint where stiffness does not seriously affect function. This may be a treatment of choice. For example, doing an ankle replacement surgery, which does not have a very good prognosis, it's better to do joint orthodesis, that is ankle orthodesis. What would that happen? Although dorsiflexion and plantar flexion would be compromised because the joint would be fused, as you can appreciate it over here, but in a way that does not actually affect walking. But if you consider the take example of knee joints, we cannot directly go for orthodesis of the knee joint. Although knee joint orthodesis is done in the cases where the function is already severely compromised. For example, if there was a patient who had a polio limb, had multiple joint infections, had septic arthritis or chronic osteomyelitis of the femur, in that kind of a scenario, his life is already very miserable. So then probably orthodesis of the knee joint is a good option. But usually in the case of knee, as it's flexion and extension and it's a very important joint, we usually go for knee arthroplasty. So that is something we have to remember, that every joint can be fused, but we have to consider the functional impact of that orthodesis. What would be the life of the patient after we have done the orthodesis of the joint? It's basically examples include spine. Spine can be easily fused, but then fusion usually results in decreased mobility. Tarsus, ankle, even thumb, metacarpophalangeal joint. But fusion of the thumb metacarpophalangeal joint would mean the loss of pinch function, which is one of the very important hand functions of the human body. Also for the stiff knee or a flare shoulder, but usually it's kind of arthrodesis is something which is actually left at the last. This is the last resort, that usually if we cannot do anything about the joint, the best is just to fuse it so that the patient can have at least, although non-mobile joint, but at least pain-free non-mobile joint. Alternative to arthrodesis is arthroplasty or osteotomy. Usually in case of knee and hip, the first preference is to go for arthroplasty, but there are always conditions in which is so infective and the problem is patient is going to be so much problematic that you cannot go for arthroplasty. Then the best option is to go for arthrodesis. Or for example, if there is a problem of AVN hip and the patient is around, let's say, 20-year-old and he is a laborer and hard worker, then instead of going for arthroplasty, which is going to fail in 5 to 10 years, it's better to go for arthrodesis of the hip joint. At least you're going to give that patient a painless, stable joint rather than giving a mobile joint, but it's still going to be painful. Now coming to what are the principle of arthrodesis. Principle, first of all, you need to expose it. Both the joint surfaces of the joint, that is the bone above and bone below the joint, should be exposed. Extensile incisions are usually required. It cannot be done through minimal invasive approaches, although it can be at times, but usually it's done through extensile approach. For example, smaller joints of hand can be approached by arthroscopic means, but that is usually reserved for carpals and thumb and all that, usually not for large joints such as knee and ankle. Then it is a preparation. Both article surface should be denuded of the cartilage, because otherwise cartilage is going to be damaged and it's going to cause pain, because we need to give patient a painless joint. Actually, that is the paramount importance. When we are compromising mobility of the joint, then we cannot compromise on the pain factor. If there is a painful as well as immobile joint, that is going to be a disaster for the patient. Then subchondral bone should be feathered to increase the contact area. Then it's the coaptation, preparation of surfaces as opposed to the optimum position. Then every joint has a certain positions, how much varus, valgus, abduction, adduction should be maintained in the joint to keep it in the arthrodesis position. For shoulder, for elbow, for hip, knee and ankle, all joints have different degrees of position which needs to maintain, and we need to fix and fuse the joint in that position so that the optimal system of the body is not affected. Then is the fixation. Usually, for example, if we take the example of ankle can be fixed with a single intramedullary rod through the calcanea up to the tibia. It can be fixed with screws, or we can put plates around it so that it can be fixed. So then that is probably the choice, is usually sometimes surgeon's preference as well, how that surgeon wants to arthrodese a joint. It could be internal or external. Similarly, internal means screws, use of plates, use of intermediary rods, or external could be use of Elazaroff. Then whether they want to use bone grafts or not, depending upon, for example, if we're taking subtalar arthrodesis, sometimes we need to put in a graft because we are doing it for AVN of the talus, but sometimes we don't need to. So depending upon the situation, sometimes the grafts are used, sometimes they're not really required to use for the arthrodesis. Complication, as you know, you want to fuse a joint and it does not fuse. That is a non-union with the formation of pseudoarthrosis. This is one of the worst complications you can have after arthrodesis. Now coming to the arthroplasty. Arthroplasty means joint replacement. Simple, if you translate that, is plasty is replacement and arthro is the joint. The surgical refashioning of a joint aims to relieve pain and restrain or restore movement. Now with the arthrodesis, you knew that it was actually a painless joint, but there was loss of function. There was no mobility as a joint. The joint was not mobile enough to make any movement over it. Arthroplasty does two things. It actually relieves patient of the pain, which is the paramount importance, and along with it, it also retains the motion, which is also important at times. For example, if the patient is having a total knee replacement for osteoarthritis knee, that means the patient would have been in constant pain for, let's see, maybe 4 to 5 years or 7 years at times. So if you're doing orthodesis, that will fuse the knee, result in a painless joint, but that will mean the straight extended knee. That patient will not be able to flex the knee. So if we are going for total knee replacement, that will not only help to resolve the pain, but also will restore the movements at the knee joint. That is the flexion, extension, some degree of rotation, which is actually also possible on the knee. So this could be through excision arthroscopy. A partial replacement is actually when only one condyle, for example, if the patient has a genovarum or genovalgum, that is, there is increased knocked knee or bending knees. What results in this is certain loading patterns are such that one condyle, for example, either the medial or the lateral condyle is affected more than the other condyle. In certain conditions, if the patient is young and in certain circumstances, we have specific indications for unicondylar knee arthroplasty. If they are being met, then we can result in replacement of the single condyle. That is, we can perform a unicondylar knee on the patient. But depending upon whether that patient fulfills the criteria which comes under the indication of unicondylar knee arthroplasty, otherwise we may have to eventually go for total knee arthroplasty, in which both the condyles are actually replaced. That leads to joint, or it could be total joint replacement, or it could be partial joint replacement. Now there is a term called the excision arthroplasty. Although it's unfortunately it's called as arthroplasty, but it's not exactly the joint replacement being done. What happens in sometimes, for example, shoulder joint replacement was done, it was very good, but got infected from Proponium acnes, which is a very notorious bacteria. If it infects that shoulder joint, sometimes very difficult to eradicate infection, and despite eradication, we are unable to completely eradicate the infection. Then, once the implant gets infected and a biofilm is made, it's very difficult to remove that biofilm. Therefore, you have to take out all the implant. Especially in the case of the shoulder, sometimes what they do is they have to excise all out. The section of the whole implant is done, head of the humerus is taken out, and actually the joint is left as such. There is no replacement of the joint. Although it is called as arthroplasty, but actually the replacement is not done. So although it's rarely done, and it's not a very good surgery because you are leaving kind of a flail limb over there, but sometimes you have to do it. There's no other option but to do it. So it's sufficient bone is excised, excision is actually articulating parts of the joint is removed, gap at which the movement occur, although some degree of movement would still occur because other joints are functioning and limb's overall function is preserved, but although there is still gross limitation of the movement of the joint. As I told you, movement is always limited in this case. And what actually the process and the mindset behind this is that there is going to be increased fibrosis over there, and this fibrous tissue which is going to be present in the gap is going to be acting as a kind of a bridge between the proximal and the distal bone. Although there is no implant or no actually bony bridge coverage between the proximal and distal portion of the joint, which is actually has been excised. It's kind of, if you take the example of the shoulder, you have removed the proximal part of the humerus and the head of the humerus, and there's a huge gap between them, around 4 to 5 centimeters. But this fibrous tissue formed between the glenoid of the scapula and the mid shaft of the humerus can act as a kind of a bridge in which some degree of movement can take place. In this section, we have briefly gone through what are the different joint surgeries. For example, what is arthrotomy? That is opening up the joint, which could be done for multiple indications such as abscess, drainage of hematoma. It could be for the synovium, synovectomy, or even for the biopsy. Although it's a good procedure, but it has its own pros and cons, and there are always some complications associated with for arthrotomy as well, and most notorious of them is infection. Then we have briefly gone through what is arthroplasty. This is the replacement of the joint. It could be total or it could be partial. And lastly, we have gone through the Arthrodesis as well. Arthrodesis is the fusion of the joint. Although it's a good procedure, at times it gives us a painless joint, but the disadvantage is that it actually compromises mobility of the joint. Keep watching sqadia.com. Thank you very much.